Imagine someone handing you a needle and basically telling you it needs to go into the absolute most sensitive, intimate part of your body.
Right, your brain instantly just screams, absolutely not.
Exactly. I mean, every evolutionary instinct you have is firing off an alarm bell. Yet every single day, thousands of patients undergo these exact injections. And the biggest hurdle doctors face isn't, the needle itself. It's actually hacking the patient's brain before that needle even comes close to the skin.
Yeah, it's a completely different way of looking at medicine because, well, we usually think of healthcare as this simple equation of cause and effect, right?
Sure, like you have an infection, you get an antibiotic, you feel better.
Exactly. But when you step into the world of highly sensitive, intimate medical procedures, that simple equation is, it's entirely useless.
Well, welcome to this deep dive. Today, we are taking you on a journey into a highly specific, pretty intense medical scenario. The mission for today's deep dive is to explore the clinical protocol for counseling patients who experience intense situational anxiety and fear regarding internal intimate injections.
Which is such a fascinating area of medicine.
It really is. We're talking about life-changing treatments for conditions like high-tone pelvic floor dysfunction, severe vaginismus, and erectile dysfunction.
And just to give you a sense of the medical landscape we're exploring here,
Yeah.
let's just quickly define what we are actually treating because high-tone pelvic floor dysfunction, for instance, means the pelvic floor muscles are locked in this chronic, painful spasm. They literally can't relax.
Right.
And vaginismus is similar. It's characterized by involuntary muscle spasms that make penetration incredibly painful or, in a lot of cases, even impossible.
Yeah.
And to treat these conditions, the protocols involve things like pelvic floor trigger point injections or even Botox administered directly into the vaginal muscles.
Wow, Botox. And for erectile dysfunction, we're looking at intracavernosal injections, which is often abbreviated as ICI. Now, the hook here, the thing that makes this entire topic so compelling, is the success rate.
Oh, it's massive.
Yeah. I mean, these treatments are incredibly effective. The response rates for ICI therapy are between 70 and 90% for men who just haven't responded to oral medications. But, and this is a huge but, these procedures involve putting needles into areas of the human body that are biologically wired to avoid sharp objects at all costs.
Which brings us right to the core dilemma. Because the clinical landscape we are looking at today reveals that the biggest barrier to healing isn't the disease itself, and it certainly isn't a lack of effective medication.
So what is it?
It is the human brain's anticipation of pain.
Here's where it gets really interesting. Think about standing on a high dive as a kid. You're up there, your toes are curled over the edge of the board, looking down at the water, and you are just physically shaking.
Oh yeah, the worst feeling.
The anticipation is agonizing. Your stomach is in knots. But the actual jump, the 3 seconds of falling and the impact with the water, it's brief and totally manageable. In these intimate medical procedures, the anxiety is the primary symptom that needs to be treated first. The anticipation is massively disconnected from the reality of the physical event.
That high dive analogy captures the exact psychological barrier clinicians face perfectly.
Yeah.
And it's actually completely supported by the clinical data. There's this really fascinating piece of research called the Baird study that illustrates this disconnect beautifully.
What did they look at?
They specifically examined patients undergoing their very first ICI treatment for erectile dysfunction. So before the clinician even brought out the medication, researchers asked the men to predict how much pain they would experience on a scale of 1 to 10.
Oh, wow. And what did they guess?
The average prediction was a 5.29.
Okay, so they are bracing themselves for moderate to severe pain, over a 5 out of 10. I mean, in their minds, they are preparing for a serious ordeal.
Exactly the case. But then, after the injection was actually administered, they asked those same men to rate the pain they actually experienced.
Let me guess, it was lower.
Significantly lower. In fact, 59% of men in related studies rated the actual injection pain as a 2 or less out of 10.
A 2 or less.
Yeah. They often describe the sensation as being, no more painful than a standard blood draw in their arm or just a tiny pinch.
So the brain is essentially running this worst-case scenario simulation that just completely overshoots the reality. I mean, it's trying to protect the body, but it's wildly overcompensating.
It is overcompensating severely. But that simulation has very real, very damaging consequences. Because the brain believes the pain will be a 5.29, the body reacts as if it's in grave danger.
Right, fight or flight.
Exactly. At that first injection, 65% of men reported having high anxiety. Now, the good news is that this anxiety is highly situational. By 4 months of continuing the therapy, as the patients realized the pain was minimal and they got used to the routine, that high anxiety dropped down to 42%.
But getting them to that 4-month mark is the mountain clinicians have to climb, isn't it? Because the stakes of this anxiety are huge. We're looking at dropout rates for these injection therapies that are notoriously high.
Oh, incredibly high.
Yeah, I mean, some studies show dropout rates climbing all the way to 47.8%. Nearly half of the patients who desperately need this therapy, who finally have a solution to their medical issue, just walk away.
And they drop out for very specific psychological reasons.
Uh-huh.
It's the fear of the needle itself, the perceived pain they are just convinced is coming, or acute anxiety over potential side effects.
Like what kind of side effects?
Well, for ICI, a major fear is priapism, which is a prolonged erection lasting over 4 hours that literally requires an emergency room visit.
Oh, yikes. Yeah, that would be terrifying.
Right. And for patients with vaginismus, the fear is often rooted in the very pain that the condition causes. Their brain is already wired to protect that pelvic area from pain at all costs, so the idea of introducing a needle triggers this intense, self-fulfilling loop of panic and muscle tension.
So if you have a patient sitting there, absolutely terrified, anticipating a level of pain that is entirely inaccurate, but experiencing fear that is 100% real, how does a clinician even begin? Like, they can't just walk into the room with a syringe and say, all right, let's do this.
They absolutely cannot. To get past that barrier, clinicians have to build an initial foundation of trust through what is fundamentally a trauma-informed protocol. And this redesign of the clinical approach actually starts before the patient even takes off a single piece of clothing.
Which makes total sense when you think about the vulnerability involved. The consultation environment just has to be radically different.
Think about it. Imagine trying to have a highly nuanced, emotionally loaded conversation about your deepest anxieties or, potentially a history of sexual trauma while you are sitting half naked on an exam table wearing one of those flimsy, crinkly paper gowns.
Oh, it's the worst. The power dynamic is completely skewed. You feel exposed, cold, and just entirely powerless.
Exactly. So the protocol dictates that conversations about procedural anxiety, fear of pain, and any history of trauma must happen while the patient is fully clothed. They are seated in a comfortable chair, eye to level with the clinician.
It's about restoring agency before the procedure even begins, making them feel like a partner in the process rather than just a subject on a table. And I noticed from the sources the language they use is incredibly deliberate too.
The vocabulary shifts are subtle, but they are crucial for keeping the nervous system calm. Trauma-informed care requires avoiding words that might trigger past traumatic memories or feelings of helplessness.
Like what?
For example, in gynecological exams or pelvic floor injections, clinicians are strictly trained to avoid the word stirrups.
Really? Just the word itself?
Yeah, that word can feel overly clinical, restrictive, or evoke a sense of being trapped. So instead, they use the term footrests.
Oh, interesting. And they avoid giving commands like scoot down, right? Instead, they'll say something like, bring your hips to meet your hands. They avoid bedroom language entirely, opting for safe, descriptive, clinical terms. And consent isn't just a piece of paper you sign at the front desk with a clipboard, it's continuous.
Continuous consent is the absolute bedrock of this protocol.
Yeah.
The patient is explicitly told, usually multiple times, that they have total control over the pacing. They're told, nothing happens without your say-so, and you can ask me to pause or stop at any time. The clinician narrates every single step before it happens.
Okay, I have to push back here because this is where my skepticism kicks in.
Mm.
All of this communication, the clothed consultation, the careful wording, the continuous consent, avoiding the word stirrups, it all sounds absolutely wonderful for bedside manner. It is polite, it is respectful, and it makes for a nice Yelp review. But does talking to a patient differently actually reduce the physical pain of a needle-piercing human tissue?
If we connect this to the bigger picture, the answer is a definitive, scientifically proven yes. It literally physically changes the experience of pain.
Wait, really? You're telling me that just by changing my vocabulary, I can act as a local anesthetic? I mean, a needle is a needle, right? Tissue damage is tissue damage.
That is the old mechanical way of thinking about medicine. It assumes pain is just a direct one-way signal from the site of the tissue damage straight up to the brain. But that is not how human neurology works.
Okay, so how does it work?
Pain is heavily modulated by the central nervous system. When a patient feels helpless, trapped, or terrified, like sitting in a paper gown waiting for an intimate injection, they can't control. Their central nervous system is in a state of high alert. Their amygdala is screaming. The body's flooded with stress hormones like cortisol and adrenaline.
Okay, I'm with you on the stress hormones, but how does that change the physical sensation of the needle?
Because those stress hormones actually sensitize your nerve endings. It is a phenomenon called hyperalgesia.
Overall, geez.
Right. When your body thinks it is in a survival situation, it lowers the threshold for what the brain perceives as painful. It wants you to feel everything so you can escape danger. So an injection that should feel like a 2 suddenly feels like a 6 or a 7 because your terrified nervous system is amplifying the signal.
Oh, wow. So the fear literally turns up the volume dial on the pain receptors and the tissue.
Precisely. So by offering choices and giving the patient continuous consent, you are sending profound safety signals to the brain. You are telling the amygdala to stand down.
That is wild.
Yeah. For example, some clinicians offer the patient the option to self-insert the speculum during a pelvic exam, or they allow a support person in the room. By giving the patient that agency, the threat response is lowered, cortisol drops, the central nervous system dials down the volume, which physically, tangibly reduces the sensation of pain.
That is incredible. The brain is so powerful that a sense of control acts as a localized neurological anesthetic. But they don't just rely on words and agency, right? They also use actual procedural adjustment, physical safety nets, to prove to the patient that it won't be a disaster.
They absolutely do.
Yeah,
For erectile dysfunction patients starting ICI, doctors don't just hand them a prescription for a full dose, give them a syringe, and send them home.
I would hope not.
Right? They perform supervised in-office test injections. This is crucial for building physical trust. They use very fine-gauge needles, similar to the tiny needles used for insulin. And for highly anxious patients, say, a man between 18 and 40 who's dealing with severe situational anxiety, they will start with a very low dose of a low-concentration medication, like Trimix.
And Trimix is a specific blend of medications that dilate the blood vessels, right?
Yes, Trimix is a compounded mixture of 3 different vasodilating drugs. But by starting with a highly diluted tiny dose in the clinic, the doctor's managing expectations.
So the goal isn't necessarily a perfect clinical result on day one. The goal is just to show the patient they can survive the injection without triggering that dreaded 4-hour erection that sends them to the ER.
Exactly. It is a physical demonstration of safety. The doctor is proving, see, we did it, it barely hurt, and you are perfectly fine. And similarly, for gynecological injections or exams, clinicians will offer numbing creams, use the smallest possible instruments, and even use mild sedation like nitrous oxide laughing gas just to take the edge off the acute anxiety so the patient's nervous system can tolerate the procedure without going into a spasm.
Okay, let's unpack this. We've talked about trauma-informed care, the careful language, the nervous system modulation, the test runs with Trimix. That all makes total sense for baseline anxiety or even moderate situational fear. But what happens when a patient has a severe clinical phobia?
It's a whole different ballgame.
Right. I'm talking about trypanophobia, a deeply rooted, overwhelming, paralyzing fear of needles. If someone has a phobia so severe that they can't even look at a picture of the syringe without hyperventilating, but they desperately need a life-changing treatment, like Botox injections to cure their severe vaginas, that polite vocabulary and a comfy chair aren't going to cut it. What is the protocol then?
You've hit on the exact threshold where the standard trauma-informed protocol has to be escalated. When you cross the line from situational anxiety into a clinical phobia,
Yeah.
you have to bring in heavy-duty psychological interventions to literally rewire the brain and the body.
So how do you physically get them to tolerate the treatment? Are we talking about traditional therapy before they can even go to the clinic?
Often, yes. It usually starts with cognitive behavioral therapy, or CBT. CBT is used to identify and actively challenge catastrophic thoughts.
It's like thinking the needle's going to destroy them.
Exactly. If a patient fundamentally believes this needle is going to cause unbearable agony, my body will be irreparably damaged and I will lose my mind. The therapist helps them dismantle that irrational fear. They examine the evidence. They replace those catastrophic predictions with neutral, reality-based associations.
But knowing something is irrational doesn't stop the panic. I mean, you can't just logic someone out of a phobia, right?
And you can't, because the phobia lives in the primitive part of the brain that doesn't care about logic at all, which is why CBT is almost always paired with exposure therapy, specifically systematic desensitization. And the how and why of this process is fascinating. It relies on a neurological process called habituation.
Habituation. So teaching the brain to just get used to it.
Essentially, yes.
Yeah.
But it has to be a highly controlled, hierarchical process. A therapist might start by just having the patient look at a cartoon drawing of a needle. The patient's anxiety will spike, but they sit with it until the anxiety naturally subsides until they habituate.
I see.
Once the brain forms a new neural pathway that says, looking at this picture is safe, they move up the hierarchy.
So they might move to looking at a real photo, then maybe having an empty syringe without a needle sitting across the room.
Exactly. Then holding the plastic syringe, then holding a real needle with the cap on, then eventually pressing the blunt end of a pen against their skin to simulate the pressure. The key to exposure therapy is keeping the sympathetic nervous system, the fight or flight response, below the threshold of absolute panic. You are giving the brain tiny, manageable doses of the stressors so it learns, step by step, that the catastrophe it predicted isn't going to happen.
That makes so much sense. You have to build the ladder rung by rung. But there's a physical reaction to needle phobias that completely blew my mind when we were preparing for this deep dive. Because needle phobia, specifically blood injection injury phobia, triggers something in the human body that almost no other phobia does.
You're referring to the vasovagal response.
Yes.
It is a uniquely fascinating and incredibly frustrating physiological phenomenon. When most people encounter something they have a phobia of, say, a massive spider or looking down from a terrifying height, their sympathetic nervous system kicks into high gear. Their heart rate goes up, their blood pressure spikes, their muscles tense up. It's the classic fight-or-flight response.
Right. The body's preparing to either sprint away as fast as possible or, punch the spider.
But with needle or blood phobias, the body does something entirely different. It exhibits a diphasic or two-phase response. First, there is a very brief spike in heart rate and blood pressure, just like normal fear, but then, almost immediately, it is followed by a massive, violent drop in blood pressure and heart rate. The parasympathetic nervous system slams on the brakes way too hard.
And because the blood pressure bottoms out, the blood rapidly drains from the head, which restricts cerebral blood flow. And that is exactly why people faint or pass out cold when they see a needle or blood. But why on earth would the body do that? Fainting seems like a terrible survival strategy if you're in danger.
Evolutionary biologists and psychologists have a brilliant theory about this. Think back to our hunter-gatherer ancestors thousands of years ago. If you were in a conflict with a predator or a rival tribe, and you sustained a deep, penetrating wound, a spear, a bite, a deep laceration, and you started bleeding profusely before the era of modern medicine, what was your biggest threat?
Bleeding to death, obviously.
Right. So if the sight of your own blood or the feeling of a deep puncture wound triggered a massive drop in blood pressure, that drop in pressure would physically slow the bleeding. It acts as an internal systemic tourniquet.
Oh, wow.
Yeah. Fainting and lying flat on the ground would keep blood in your vital organs, drastically increasing your chances of surviving the injury and letting a blood clot form.
That is unbelievable. So the body sees a tiny medical needle, mistakes it for a spear wound, and just plummets your blood pressure to save your life.
It's an ancient survival mechanism playing out in a modern clinic. But while it might have saved a caveman, it is a huge barrier to getting modern medical care.
Which leads to a really counterintuitive treatment. Okay, let's unpack this. Because usually when we are anxious at the doctor, the nurse tells us to take a deep breath, let our shoulders down, unclench our jaw, and just relax our muscles. But for needle phobias, because of this ancient fainting response, the clinical protocol is the exact opposite.
Yes, and this distinction is absolutely critical. If a clinician tells a needle-phobic patient to just relax and breathe deeply, they can actually cause the patient to faint.
Seriously?
Yeah, because deep relaxation lowers blood pressure even further, accelerating that dangerous drop. Instead, the protocol uses a physiological hack called applied tension.
Applied tension, so you intentionally tense up your muscles.
Exactly. Patients are specifically trained to intentionally flex their core abdominal muscles, their legs, and their arms. They hold this tension for 10 to 15 seconds, release slightly, and repeat.
And what does that do?
By clenching those large muscle groups, they are physically forcing the blood vessels to constrict and forcing their blood pressure to stay elevated. They are taught to recognize the early warning signs of a faint, feeling clammy, feeling dizzy, getting tunnel vision, and the moment they feel that, they apply the muscle tension. It physically counteracts the body's natural drop in blood pressure and stops the vasovagal reaction in its tracks.
That is the ultimate biological life hack. You are literally flexing your leg muscles to fight off your own nervous system's attempt to make you pass out.
It is highly effective.
Yeah.
And when you combine applied tension with the exposure therapy we discussed, you are fully equipping the patient. You give them the psychological tools to handle the irrational fear and the physical tools to handle their body's evolutionary reaction to it.
So let's look at how all these heavy-duty interventions come together in a real clinical scenario. Let's look at the treatment for severe vaginismus using Botox injections. Because it's not just a quick prick of a needle and you're sent out to the parking lot. The protocol for this requires a massive, comprehensive, multi-step rehabilitation.
It has to be comprehensive. Because vaginismus involves both severe physical spasms of the pelvic floor and profound psychological fear of penetration, the injection itself is merely the starting line.
So what's the first step?
For severe cases, the protocol often involves bringing the patient into an operating room and putting them under mild systemic anesthesia so they do not experience the trauma of the needle at all. While they are completely asleep and their muscles are finally relaxed, the Botox is injected into the hypertonic pelvic muscles to temporarily paralyze those spasms.
All right.
But crucially, immediately following the injection, a vaginal dilator is placed.
So when the patient wakes up in the recovery room, the dilator is already in place and they haven't felt the pain of insertion.
That is the key. It completely severs the mental cycle of anticipating pain upon penetration. They wake up and their brain realizes, wait, there is something there and it doesn't hurt.
That's genius.
But the protocol doesn't stop in the recovery room. That's just day one. It requires next-day supervised dilation with the clinical team, where the patient practices inserting and removing the dilator in a safe environment. It requires ongoing intensive physical therapy to learn how to intentionally identify and relax the pelvic floor muscles.
And relationship counseling is a mandatory part of the protocol, too, from what I read.
It is essential because if a patient has been unable to have intercourse or has suffered immense pain during intimacy for years, it deeply affects the dynamic with their partner. There is guilt, frustration, and emotional distance. The treatment has to be a full mind-body rehabilitation.
It really hits every angle.
It has to. It addresses the physical muscles with Botox, the nervous system with safe exposure, the emotional trauma, and the relational impact. If a doctor only injects the Botox and skips the psychosexual counseling and the physical therapy, the failure rate is incredibly high. The spasms will just return once the Botox wears off because the psychological trigger is still there.
So, what does this all mean? When you look at the treatment of conditions that require these incredibly sensitive, intimate injections, whether it's for severe pelvic floor dysfunction, erectile dysfunction, or vaginismus, it isn't just about the medication inside the syringe. Honestly, the medicine is almost the easy part.
It really is.
The real treatment is this delicate, multidisciplinary dance. It's the trauma-informed communication where a clinician avoids triggering language to keep cortisol levels low. It's the in-office practice runs with tiny needles and trimix to build physical trust. It's the psychological rewiring using hierarchical exposure therapy and the evolutionary physical hacks like applied tension.
What's fascinating here is that modern medicine is finally waking up and recognizing that the human brain's anticipation of pain is often the biggest obstacle to healing. For a long, long time, the medical establishment viewed patient fear as an annoyance.
Just something to push through.
Exactly. It was just a nuisance, something a patient needed to get over. But this protocol proves that acknowledging that fear treating the anxiety as a primary physiological clinical symptom rather than dismissing it as a weakness is actually the most effective clinical tool we have to ensure patients get the life-changing care they need.
It really changes how you view a simple trip to the doctor. Which leaves me with a thought I haven't been able to shake since we started digging into all this. We know that these methods work. We know that giving a patient total control to stop, completely avoiding triggering language, utilizing biological hacks like applied tension, and doing clothed consultations, we know this drastically reduces physical pain and anxiety for the most sensitive, terrifying injections imaginable.
The data is clear on that.
Right. So if we have a protocol that is scientifically proving to literally lower the volume on human pain receptors by creating psychological safety, why isn't this trauma-informed approach the mandatory standard of care for all medical procedures? From a routine dental visit to a standard flu shot, why isn't every clinic on Earth operating this way? It is definitely something to think about the next time you find yourself shivering on that crinkly paper gown.